Hello everyone. Today I have Mr. Tom Symondson, the Chief Executive Officer of Victorian Healthcare Association with us to answer a number of questions and share some insights into the issues related to quality and safety service our health services provide. And welcome, Tom.
Thank you.
And do you want to give a bit background of what VHA does?
So the Victorian Healthcare Association is the peak body for public hospitals and community health services in Victoria. We've been around for almost 80 years, and we have about 95% of the public hospitals and community health services in our membership. So we advocate for them, we are their voice, and we also support them to do what they do as well as they possibly can.
So you'll be the right person to answer some of the questions related to where our health services are at now today. So I prepared a number of questions for you to address. Since the implementation of the Australian Health Service Safety and Quality accreditations, we across Australian hospital system, we have high expectations that our hospital system, the service they provide will be standardized, and hospital system will be a much safer place for patients to be treated and work in. But however, there are still ongoing healthcare or hospital scandals that put doubt in our minds. So, and given the unique position of VHA in supporting the Victorian Health Services and acting as a communication channel between the government and the health services they fund, I'm sure you will be able to give us some insight into, in terms of how health services been taking a more proactive role in improving the quality and safety service they provide, and any views or insights, that would be great.
So accreditation has been extremely helpful in increasing people's awareness around quality and safety. But the idea that it's anything more than a baseline, a safety net, is only just starting to become well known. You know, it really isn't going to lead to your service being a world-class, excellent service just because you're accredited. Accreditation is something that health services go through to make sure that they are reaching those basic standards, but that's what they are basic standards. And I think that has been highlighted by some of the crises or the scandals that you've mentioned. Wherever we see things go wrong in a hospital, those hospitals were accredited. So accreditation in itself is not enough to ensure that we have a standardized, high quality, safe health system all the time and everywhere. It's one part of that, and it's a really important part of that. But at the same time, health services, they have to go beyond accreditation. They have to work out what is it going to take to become a world-class health service. And accreditation is a good starting point, but that's probably all it is.
You mentioned world-class health services. I'm not going to ask you to specify what that means, but I would like you to picture. I know that different health services provide different level of quality and safety service. But I want you to picture a best health services, say in Victoria, that really adhering to best practice in service provision. And what are the best aspects of this health service that actually made this health service stand out among the others?
So I think, I won't try and define world-class because it is something that we throw around probably more than we should. But Victoria actually has a very strong health system. It has a very safe health system. The reason that the recent events at Bacchus Marsh shocked everybody so much is that Victoria had not had one of these kinds of crises in a very long time, whereas other states had. So we have a safe and high quality system, but of course we can do better. One of the things that the strongest and the best performing health services will have in common is that they've tackled their cultural issues. So it's not, accreditation is about having the right processes in place, and that's very important. But to become an excellent health service, you have to address the culture. You have to ensure that you are addressing bullying, harassment within your staff. You have to make sure that you have a culture that's focused on quality and safety, rather than a culture that is not unified, where every team sort of thinks differently. The best health services are the ones where, from the board table through the CEO down to people on the front line, everybody understands what quality and safety looks like and how they contribute to that in their day-to-day job. You know, there's the story about the cleaner who thinks that they're actually there to care for the patients because they come into their room every day, rather than just being a cleaner. It's about making sure that the culture throughout the whole health system, the whole health service, is completely focused on that end point. And I think, you know, whilst accreditation is a great test of your processes and your approach, you cannot really test for that culture. So it's about making sure that that culture is really engendered and focused on. And we've seen recently a lot of attention put on the problems of bullying within the health system, and we know that they exist. So the health services that are really trying to tackle that, or really succeeding in tackling that, will be the ones that reap the benefits eventually.
So the culture you mentioned also probably includes open culture that there's no blame when mistakes made, adverse events happen, and also transparency in the way that how health services solve the problems and what's the outcomes of the actions they take.
Well, I would sort of just contest one bit of that, which is the no blame culture. I don't think we should blame people for making mistakes if they learn from the mistakes and they don't do it again. There comes a point where, you know, the kinds of sentinel events that we still see too many of, you know, the wrong limb amputated, or, you know, people having instruments left inside them after an operation. And this happens far too often. I actually think if people aren't learning from those mistakes, then probably we should be very clear, not about blame, but about accountability. It's not a no accountability environment, and I think that's where people get a little bit mixed up with no blame and no accountability. You have to have accountability. But yes, it's a kind of culture where there is a level of safe space, so that you're not so terrified of making a mistake that you take no risk whatsoever. You know, our health system environment is inherently risky. What we have to spend our time doing is making sure that that risk is as low as possible, but you can't eliminate it. And it's when people try to eliminate risk entirely that they fall. They fail, they fall over, because you can't. To provide an excellent service, you have to embrace that and work out how to reduce the risk as much as possible. So, you know, the blame thing is sort of it's based on the idea that you can get rid of risk altogether, which you can't. So, you know, how do you help people to learn from those mistakes and make sure that the mistakes that do happen are not going to massively impact on an individual's outcomes or on their health? That's what we have to focus on.
So we actually, when bad things happen, we need to actually look into whether we have a system, we have a process that's comprehensive enough for us to follow, to avoid those risks and avoid those mistakes that human beings can make.
Well, and I would say there's two bits of it. Yes, we have to put the process in place, but the process will only work if it chimes with the culture that you have. So if it's a process that goes again, this is why processes fail, because the process that you put in place ignores the realities of your team or your culture or your workplace. So people ignore it, or they go around it, or they see it as something that management imposed on them. So it's all about being consultative and ensuring that you get the right people around the table to develop those processes. Clinicians have to be a really big part of that, not just leading clinicians, but all clinicians, non-clinical workforce and management all have to be involved. But the other thing is really, we have in Victoria, you know, I say we have a very well-performing health system, and we do, but we also have an awful lot of individual organisations within our health system. We're unusual in Australia. We have 86 health services, 31 independent community health services. So, you know, there's a lot of organisations within our public and you know, community health system. We need to get much better at not just learning from the mistakes within one health service where the mistake occurs, but we need to get much better at sharing that knowledge across the system. So if something happens in hospital A, we should be learning about that across the whole state. And I don't think we've done enough in Victoria on that. And I think that, you know, there's been some movement on this in New South Wales, there's been some movement on this in Queensland, and there's been some movement on it here in Victoria, but not nearly enough. So how do we make sure that where those learnings occur, they are shared as broadly as possible? Because otherwise people are constantly reinventing the wheel, and that's a waste of taxpayers' money at the end of the day. And how do we actually share that knowledge?
That's a really interesting point. I think we find another opportunity to address that is sharing knowledge, sharing the mistakes we made, and sharing the lessons that we have learned, so that we can avoid that.
Not just the mistakes, but the great things that we do. So where we do something really innovative, we're just not good enough at sharing that. You know, you've got the Australian tall poppy syndrome. Nobody really wants to shout out how good they are or the great thing that they've done. But we do need to recognise when good things happen. Just because they weren't invented at this hospital doesn't mean we cannot implement them as well.
So we need inspiration to do things better.
And to learn from each other.
Yeah. So I steer the vehicle to another direction to ask you another question about regional rural area. So general speaking, rural and regional areas consist of many diverse settlements, including such farming, mining, Aboriginal, Torres Strait Islander communities. So they have raised unique or different social and economic determinants of health. And also there's population in the rural and remote areas. Generally, they are older. They have higher rates of chronic disease and also injury. And the poor infrastructures, including health infrastructure, may the access further reduce the access of health services by the populations and maximize the gaps in between health inequality in health service access and in health outcomes. So I think the government has tried the best, well, not the best, have put into effort. Yeah, I know, I like your smile. To bridge these gaps, including those such as fine doctors service and rural GPs, women GP services, something like that. So from your perspective, what are the pressing issues that we will need to address at a system and health services level in order to provide a high level quality and safe services in regional, rural and remote areas, and despite all the limitations?
So the biggest challenge that a rural community has when it comes to any kind of social infrastructure, whether it be health or educational, is that we can't provide everything physically in that location that you can have in the city centre of Melbourne or of Sydney. So, you know, we've got the Royal Melbourne Hospital cannot be replicated in every small town across the state, and neither would people expect it to be. So you have to find a way to ensure that just because you live in a rural area, you have access to all of the services that somebody that lives next door to a big major hospital in the city of Melbourne has, without actually replicating that infrastructure in their town. So one of the really big challenges that causes us is that people can't always access services outside their town because they either don't know how to, or the transport is poor, or health literacy levels are potentially lower, and need, as you said, might be higher. So you've actually got all of those things conspiring to make it more difficult to access services in a rural or remote location. And we have not historically been very good at changing the system to make up for that problem or those problems. So, you know, we haven't been great users of telehealth, for example. We haven't been great investors in the primary care and the community health system to ensure that people are really getting access to services that mean they don't have to go to the big acute hospital until something becomes really urgent. We haven't really invested in those kinds of options, and that really plays out very obviously in country areas. So, you know, you'll have, in Victoria we're very lucky, we have a lot of very good health services outside the major cities and regional centres, providing a good range of different kinds of services, but they're still not providing, you know, heart transplants or specialist burns treatment. So you still will always need to come to Melbourne or a major centre for those things. So we've got good local services, we've got excellent statewide services. We really need to do a lot more to link those together. As I mentioned earlier, Victoria has 86 health services, which is a large number of health services, and we're very proud of that model. We have locally led decision making, we have services which are tailored to the needs of that community. But there has been a tendency for those services not to see themselves all as part of one system, working together. We're doing that a lot better now, but you know, how do you get all of those services working together in a system where if you turn up at your local hospital and the thing you need isn't provided at that local hospital, there's a seamless transition into the setting you need to be in. You know, if you turn up having had a car crash, you will get transferred by air ambulance to the city. That's the extreme case. We do that extremely well. But what about chronic disease? What about you know, less acute illness or accident? You know, making sure that we've really got all of those linkages set up. Making sure that when you've been to the big city hospital to have your operation, you can recover back in the hospital in your home so that your family can come and visit you. Even those things we're not particularly good at yet. So we really have created a system that makes it suboptimal for rural communities to access. We're still very well off when it comes to the level of healthcare that we can get access to in rural Victoria, but we could be a lot better. And there are very clever ways of doing that, but we just need to focus on them more.
I think you make two really interesting points. And the first one is the one that we have been arguing that we're not doing well, is to provide continuation of care. So patients got discharged from hospital and then they just left unattended. That's why the chronic disease was not well managed and then turned into an acute episode and further burden the hospital system. And secondly, this one actually took me back to a debate I had with my students a few years ago, when the former Prime Minister Kevin Rudd saying that he want to have a vision of bridging the gap of the health outcomes between the general Australian population and the Aboriginal populations, but without any specific strategies in considering non-health infrastructure that you mentioned: public transportation, better water system, food supply, housing and education. So all those determines will impact on the health outcome, rather than just looking at how many health services we are going to build in the rural regional areas. So do you think that you mentioned a number of times that Victoria are doing really well, so you are making our Victorian really proud of ourselves. So do you think anything that really specific we need to do urgently in order to improve the continuation of care in the regional and rural areas, and also to what efforts that you, from your observation, the government has put into developing various types of infrastructure in order to improve the equity of health outcomes in the regional and rural area?
And well, yeah, the biggest challenge that we have is, people will complain about our federal model, and primary care is funded and controlled by the federal government, and acute care is funded and controlled by the state governments, and I'm not going to get into the debate about that. But what that has led to is this gap, this very artificial gap between primary care and everything else. And it's also led to state governments focusing very heavily on acute care because it's the bit they control. Now, the very great strength of Victoria is that the Victorian government maintained its community health system, which the other states really didn't. So in Victoria, our state government also focuses on a type of primary care and community health because it has put resources into that system over a very long period of time. So we are better off than other parts of the country for that. But we still, when we talk about management of chronic disease, we still don't do nearly enough to integrate the different bits and pieces of our very fragmented health and well-being sort of system, so that the person with the chronic disease, and let's remember that most people have at least one, if not, after a certain age, most people will have more than one chronic disease. So, whether it be diabetes, or diabetes is the most common one, but they'll have multiple chronic diseases. So with a very fragmented system, an acute episodic system focused on making people better and a primary care system supposedly focused on helping people, over the longer term, that are not well connected, we sort of got what we designed. We sort of got what we deserved with the structure that we put together. So governments have to do a lot more to connect those different bits of the fragmented system, and that wouldn't just help people in the country, that would help people in the city as well, people in disadvantaged communities, economically disadvantaged communities. When you look at rural communities, you actually generally do have a better connection between primary and acute, just because those communities, they're smaller and those connections are more easily built. So the local GP will probably provide services in the hospital as a visiting medical officer. The nursing staff who work in the hospital will know the families of the patients who are coming in. So that all of those relationships mean that people in rural communities are generally more able to build those connections, just because that's the way a small community works. When you get into the cities, that's much, much more difficult, because people don't have that knowledge of each other, those very close connections. So, I'd say in terms of chronic disease, whilst the outcomes aren't good in rural areas, we've probably got a better chance of making it work in those communities because of those relationships, not because of the policy environment. The policy environment doesn't make this easy at all. In fact, the current policy environment that we have completely disincentivizes looking after people's chronic conditions, or helping them to look after their own chronic conditions, because we fund GPs based on an appointment, and we fund hospitals based on an activity, a specific activity based on one condition that person presents with. We don't fund anybody. There's the healthcare homes proposal that the federal government's talked about, which is a good direction, but not enough money probably to do as much as it should. Nobody is really funded to care for the person with all of their collection of issues and diseases and health and non-health issues. We talk about social determinants all the time. Health is only it's only one very small part of that. Education and employment are the biggest and most impactful social determinants. So, how are we? It could become a circular conversation, but I think it's fair to say that we have not done nearly enough to link our health system together and the other bits of the system.
And we never can do enough. But I'm really interested in the point that you made, that we should not look at a person as an episode of disease or a person with a certain needs, but actually look at the person as a whole. Just like when you're saying that we need to look at what services required for the system as a whole. And also interesting that you say that the rural regional areas have higher chance to provide continuation of care to patients rather than in the metro area when infrastructure is much better. But do you think that from Medicare locals, back a few years ago and to the primary healthcare networks now, we are actually on the track of doing better in terms of managing chronic disease in the community and treating patients as a person with different aspects of needs or different types of needs, rather than just shifting responsibility between different types of services?
I think there are a lot of things happening that make me feel very optimistic about the system's ability in the future to look after chronic disease and after, as I said, the individual, rather than just whatever happens, whatever they've turned up to the hospital because of. So the primary healthcare networks are tasked with starting to look at that coordinating piece, and Medicare locals did that before them, and divisions of general practice before the Medicare locals. So there is a sort of a continuing trend towards the Commonwealth trying to lead to service coordination, not mandate it, but lead to service coordination. And I think the PHNs probably have the best chance compared to the Medicare locals and the divisions of doing that, because they have some scale. And their focus has to be on building relationships with all of the existing providers to make sure that they're sort of coordinating and commissioning, rather than sort of trying to force a solution on people, because that won't work. It has to be communication and working with people. That's the priority. So PHNs are a really important lever. We also have, as I mentioned, we have the healthcare home proposal. I'm not excited about the proposal itself because it's not big enough. But the fact that a Commonwealth government is talking the language of the healthcare home is exciting in itself. As a principle, the fact that they're actually starting to have that conversation and talk about the potential to manage someone's health rather than the 15-minute appointment with the GP. Moving away from that language is really positive. And then in Victoria, we've got what's called the Health Links program, where the Victorian government is encouraging hospitals which are funded based on activity to use a small proportion of that money to support what you might call the frequent flyers, the people who turn up at hospitals a disproportionate number of times, and any hospital will have a cohort of those people who are turning up frequently and costing the system a lot of money and not getting good outcomes for themselves. The Victorian government, through this Health Links program, is encouraging hospitals to actually address those people, use some of the money that it would otherwise use as activity-based funding for a sort of a pool, probably a bit grand to call it a pooled budget, but essentially a pooled budget of money that can be spent on the needs of that individual, rather than just waiting until they turn up at the hospital the next time. So all of those things put together, PHN's Healthcare Homes, Health Links, starts to show that there's a trend in the direction of actually doing something about chronic and complex conditions and people who have them. We always talk about the conditions. There's all of these people with diabetes. There's all of these people with whatever. And the reality is they're all individuals.
Yep.
They view themselves as individuals. Why wouldn't we? So I think there is that trend in that direction. We haven't done enough. We know we haven't done enough, but there's probably no point beating ourselves up about that. We're going in the right direction.
I really love the way that you express your opinions, really objective and optimistic, and really inspiring, Tom.
Unusual for an Englishman.
Really? I don't know that. Well, the last question that you actually mentioned, community health services, and I think you are in the best position in making this comment because you work really closely with them. We have close to 100 community health services in Victoria, and they are a really integral part of the health system and play a really vital role in reducing the burden of the hospital system by health promotion, prevention, chronic disease management. But their importance has not been, from my experience, my opinions, their importance has not been well recognized, and the investment in developing these services are far from enough. And from your perspective, what would be the barriers or systemic barriers that we need to address in order to maximize the capacity of our community health services in actually meeting the increasing demands in the community and sustaining our health system in meeting the future needs of their health, of the future health needs of the population?
So we've got a very extensive community health sector in Victoria, which is unusual in Australia.
To make us proud again.
Yeah, it's something that Victorians should be rightly proud of. And I'm biased because they're members of the VHA, but I think community health in Victoria is something that other states should be looking towards, how they can replicate. In Europe, in the United States and in Canada, community health is a flourishing sector, but yet only in Victoria. In Australia's context, do we have anything like it? Now, there are community health providers in other parts of Australia, but it's only in Victoria where there really are a recognised sector. But we've got 31 independent community health services that are companies limited by guarantee, and we've got another 50 to 60 that are part of hospital services or health services. So it's somewhere between 80 and 100 community health services all up. I think you're right to say that they're not recognised as you would expect them to be, and I think that for a long time the difficulty has been that we probably have just seen them as services that are about hospital avoidance, or they're about bed substitution, and that's not at all how they see themselves. Community health services, they're really much more than avoiding people going into a hospital or helping people get out of a hospital quicker. They absolutely do those things, and that's an important part of their role. But they go much further than that. They're actually much more focused on the social model of health. They're much more focused on things like the social determinants and what they can do within their communities to make their community healthier, rather than just the person that turns up. So there's a very strong tradition within the community health sector in Victoria around really advocating for the need to improve services in their community. So not just the things that they can do themselves, but things that address the other social determinants. So making sure that education services are appropriate, making sure that people can get access to welfare when they need it, get access to social supports when they need it. So, the community health services that we have in Victoria have actually got a very broad role. Now, they haven't historically had massive amounts of money poured all over them. So we don't. When you see a massive health investment committed to by a political party in an election, it's usually an acute investment, and that's not the politician's fault. That is because that's the expectation the community has grown to expect. So what we need to do is we need to keep investing in acute health because it's incredibly important and it has a very important place in our system. But we really do need to spend a lot more time focusing on how can we invest in those community health providers and other types of social support. Because if we're going to stop people ultimately turning up in a hospital, we have to catch them a lot earlier in their disease or illness journey than we are doing. And it's the community sector that are really best placed to do that, with very strong support from the acute system, because the acute system has an interest in this. The acute system is being crushed under the pressure of demand turning up at its doors. So how do we build those partnerships? That's difficult because the acute system is funded by activity and community health is funded in a very different way. Historically, it's been funded through blocks of money. You get a block of money to do mental health services, you get a block of money to do health promotion, preventative services, and that is moving much more towards market-based systems. So things like the National Disability Insurance Scheme, things like what we used to call home and community care, but has now become the Commonwealth Home Support System. So home-based aged care, drug and alcohol services, mental health services, they're moving much more to a sort of a market-based approach. So community health is moving from this block-funded model to a much more market-based model, which is making their future challenging. But it also means that they're moving, sort of, to an extent, they're moving closer to the way that the hospital system is funded, based on service provision, based on specific outcomes or outputs. So they're actually moving closer together in terms of paradigm. But we really do need to do much more to bring those two bits of the system together, so that they can see the benefit that each other brings. And I think in Victoria we've moved a long way in that direction. But I think we probably need to do more. And it is, as you said, it is true to say that I just don't think enough people, either in the community or people who work in the health system, understand the value and the benefit of community health. It's a very large part of our sector. Out of the $17 billion that is spent on health, about $1 billion of it goes into community health. It's not a small bit of the system. So I think probably an underestimated part of the system.
Well, that's the observation I have when I'm talking to my students enrolled in Master of Public Health and Master of Health Administration. They just do not recognize the importance of community health services. I think you make 2 points I would like to ask another question. Absolute last question. I know I'm being asking too many questions. First, you mentioned a vital role for community health services advocacy. Second is it's important for them to work in partnership with other health services to maximize the benefits that they can create. Now the question is, I'm sure that you will be delighted to answer, how VHA, what VHA has been doing in supporting these two important activities that community health services should be doing, advocating the importance of serving the community as a whole, type of services required in order to make the community healthier. Secondly is how to unite the health services, different types of services together to serve better purposes.
Well, so the way we describe ourselves is that we're the peak body for the system. So obviously all of the individual organisations within the system are members, but we like to think of ourselves as advocating for the whole system. And to me, the biggest and most complex acute hospital and the smallest, most grassroots community health provider are important parts of an overall system. So the thing that they have different roles, but they are an important part of that system. The thing that we spend a lot of time doing is trying to help government to understand how best to utilise that system, because it's expensive infrastructure. It's been invested in over a long time. How best to utilise what you've already got, and one of the best ways you can utilise what you've already got is to really ramp up the community-based interventions or services, so that you can ensure that people stay well. Because what we all, it's a very glib thing to say, but we all say it, we've got an illness system, not a health system. We've got a system that fixes people who are ill. It's very good at that. It's very good at picking someone up after they've had a car crash or a major trauma. It's very good at treating the condition whilst they're in front of you. But it could be very good at keeping people well. If we were to focus on things like hospital in the home at the acute end, but community interventions, community programs, if we could utilise the massive expertise that sits within our acute hospitals and sort of engage those skills and those resources on wellness rather than sickness, I think we'd have a fantastic, probably some people would say a utopian idea of what a health system should be. And the challenges around that are immense because of the way we fund our system, the way we train our clinicians. As you've already mentioned, there's probably not a lot of people in the system who really understand the whole system or think of the system as a whole. People tend to think of it as hospitals, or if they work in community health, they think of it as community health. We need to get much better at getting people who work in the system to think of it as a system. But I see that as one of our key roles, is really telling the story of what should the system be. You don't actually need to do very much. You've got a great system. Let's just make it work better together. Let's make the person, whether you call them a patient because you're from a hospital, or a client because you're from community health, it doesn't matter what you call them, how you make the system work for them. How you allow them to travel through that system without thinking, right, I'm in community health, now I've got to work out how to get into the hospital system, now I've got to work out how to get into the aged care system. How do we make those transitions more natural for that person? Because that's what we should be aiming for. So, I see at its bluntest point, what we're here to do is to explain that system and to help people engage with the system rather than the individual bits and pieces of that system. Because at the end of the day, the community expect. I heard a presenter just recently say something quite insightful. People don't think of the health system as a system. They just think of it as a benefit of being Australian. The fact that you will have this access to health services, you don't really conceptualise it the way we in the system do. You just want to be made better or kept well. So that's at its boiled down point probably how I see us.
Tom, I think we come to the end of the interview, and I asked enough questions, but I have to say that the views and opinion you share is not only really informative, but also really inspiring. And my students and I are very much looking forward to your guest lecture in October at the Trobe. And I will place VHA's website with the link, so the audience who want to know more about the work that you do and also access the resources that VHA provide, they can just access the link to get onto the website and download those information. So thank you very much again for your time.
Thank you.